So we go on to our next speaker, Dr. Radhika Natarajan, who heads the, I may not be very right in the exactly specific part of cornea. Cornea and refractive surgery, and heads the Department of Teaching and Training at Shankar Mekaya. And I've had the experience of seeing how she conducted a wonderful conference, and I know what her skill sets are. But she's going to tell us something more. She's going to tell us about whether crossing borders for a continued education has relevance today or not.
Morning.
Thanks.
Thanks to ARC and the dynamic duo Dr. Chitra and Chitra for having me over here. So Dr. Chitra has asked me to talk on crossing the borders in cornea fellowship. I confess that I'm going to talk to you not about facts and figures, but my personal experience interacting with fellows in the last 25 years. The first border that the fellow has to cross is from textbook knowledge to the clinical connection. This is not a clinical talk, but clinical examples are the ones that we understand the best. So a fellow came to me with this patient who has corneal edema, and she was excited about discussing the options for this patient, DMEC, DSEC, etc. But if you stop and see, this is an FAT eye with a band of corneal edema at the large ICC section. This is just Brown-McLean syndrome. It's never going to progress, and the single-eye patient need not receive a transplant at all. So the point that I'm trying to make is the textbook knowledge, we have to gently nudge them into translating it into clinical relevance, which is all about practice in later life. And this has to be done over multiple casual interactions over the outpatient. They're not PT students anymore, so this has to be an interaction rather than a formal teaching. And it is definitely a mutual benefit because we go all over it again and we revise our lessons learned in the past as well. So the next border to be transited is from supervised clinical interaction to independent patient management. And I, for one, stress on them that this is best started by documenting each and every case properly. So if you start from history and symptoms and signs and so on, and you either write it down or put it down, type it down in the EMR, then you don't have any gaps, you don't miss anything in the follow-up of the patient. For example, this again is a clinical example where the patient was thought by the fellow to have keratoconus. You can see a thin cornea over there. That's because she had missed looking at the patient from the external examination point of view. And there you can see the blue sclera. So this is in fact a brittle cornea syndrome. So putting it down in the proper order helps the fellow to understand the entire case rather than having an adrenaline rush at the actual diagnosis. And equal importance should be taught to them on reviewing the patient. It is not about that rare diagnosis or that surgery that you advise, but it is about completing the treatment of the patient or what they came for. So every review has to be done by themselves and not handed over to the colleagues, and they must be taught to emphasize subspecialty care as well. So glaucoma, the retina, how to interact with them and how to bring about holistic care is also something that they learn observing all of us. The most important barrier that they will cross is their surgical training completion. So we suggest a watch and then do and then teach another kind of approach from the junior to the senior level in fellowship. While there are a number of YouTube videos available, nothing substitutes they're assisting you, they're watching you when you're doing the surgery. And I, for one, have a practice where I see the fellow before they do their independent case and go over the plan either by dummy hand movements or by a diagram like this. This is what a fellow has shown me as what she would do during the pterygium surgery. So there they miss out small points that you have to look at the medial rectus muscle before cutting the pterygium. So when they have a flowchart like this pictorially, then they know what step they should not miss. And of course, we can have an evaluation from the videos or by discussion after the procedure as well. And they must also be taught that it is not just what you do under the operating microscope. Equally or more important are the decision making which comes prior and the follow-up of the patient that comes later, because that goes to complete the surgical process. This is especially important in the context of refractive surgery because these are fully sighted patients and we cannot give them too much of hands-on to do. So the complete circuit of decision to surgery to complication management to follow-up is what completes the surgical care of the patient, which should be inculcated in them. And an important part of a fellow's life is presentations and publications. And what I suggest to them is that they document all that they do and all that they see. This way, they have a repertoire of data. And when they collect it and keep it, they don't have to scramble towards a deadline when they have to attend a meeting or something. They already have clinical or research information which can then elegantly be put together as an abstract rather than do some hodgepodge last minute preparation. And as far as publications are concerned, we have to involve them every time when we do something. It could be simple data collection or even references collating, so that they watch and know what to do. And then later we assist them or mentor them when they have to do a publication. And finally, when they see their name in print, it is an exhilarating experience both for the fellow as well as for the mentor. I love it to see their names much more than I would see my name myself. So this is a short clip I put together. These give them a mind of their own, and we need to listen to them rather than imposing what we want for them.
This 4 months of your training now. Why did you choose Shankar Vidyalaya to pursue your Cornea Fellowship program?
Shankar Vidyalaya offers a comprehensive cornea fellowship along with refractive and ocular subject exposure. And the fellowship offers a
So basically, I think we are short of time. So here we have a junior, middle level, and a senior fellow. And the clip I will play for somebody who's interested later. It showcases the change in the aspiration as they climb up the fellowship ladder. So this perspective also changes as they go along. But as clinicians, we know that it is not just about clinics and surgery. It is about the confidence that we inspire in the patient, and that is sadly not inculcated in most programs. It's something that they watch and learn. So we need to impress upon them the soft skills, because it is not necessarily the patient in whom we've diagnosed correctly or the patient whom we've surgically excellently managed that's the happiest patient, and we know that out of practice. So that is something that we must play a role model and inculcate in them also. And the sense of responsibility, especially when something goes wrong, not to palm it off or not to deflect it back. It is in fact not the problem, but the way you address the problem that stays in the mind of the patient, which we should also make them understand. And Professor Grover touched on it right now, that common sense cannot be undervalued, and it should form the bottom line of all training during the fellowship. Here again, to quote a clinical example, a fellow brought a case of what she thought was herpetic keratouveitis. You can see the cornea studded with KPs. But if you go in and see, there is a fraudulent cataract. And where do you get cataract in herpes like this? It was in fact a lens-lytic uveitis. So, looking at things and lateral thinking is something that should be inculcated. And finally, these are impressionable young people. They will have their discussion. So, they should be time and again brought back on course, and the sense of purpose has to be inculcated so that they don't waste any bit of the 2 years. That is the bridge from their studentship to their career. The final frontier that they have to conquer is passing out of the program. Some people are just happy doing the tests and getting the certification, while some more ambitious ones do the prize exams. We are equally happy, putting together the quizzes for them. And finally, when they go out, they are full-fledged professionals. They unbox their skills to the outer patient world, but they never truly go away, do they? They form a community and blend into the alumni, the SN alumni in our case, and we always share with them our ideas, our cases, our patients, and they always seek advice from us. And the umbilical cord seldom gets broken. That is all very well for both groups of patients put together. Tracks back to the patient's benefit. Thank you so very much.
Thank you. Thanks a lot, Dr. Radhika.
Thank you so much, ma'am. I just wanted to ask a question, ma'am. In all these fellowship or the comprehensive ophthalmology types, we have the basic clinical knowledge and basic surgical skills. But if they have a ruthless drop or a PCR, how many of these fellows or students are actually trained to handle such kind of complications on their own confidently?
So there are two answers to this question, Anaga. So it's easy way is to look back and see how you learn these things. That can form a mirror to how you can teach them. So during the surgical training, I feel the fellows should be asked to scrub up with the surgeon every time, along with the sister. Unfortunately, doing retinoscopy or doing the nursing assisting is kind of waning. The trainees don't do it at all. If they do it for every single case, then they are able to see it when it happens upfront, and they can learn a lesson. Today, even if I have a complication, I think back as to what my mentor did at that point in time. May not be the same thing that I'm doing, but they generally give me a guidance as to how to do it. Post fellowship, somebody was talking about refresher courses. Yes, nice on paper, it's very nice to come up with, very laborious as an organizer, you know how difficult it is to do. That is where I feel this alumni community helps. It takes as simple a thing as a WhatsApp group. They have a problem, they post it over there. I have an idea, I post it over there. We have years now. So each one gives their input, not necessarily the best every time. So the complication management becomes much easier when I take inputs from everybody or when they take inputs from members
So
of
that
the
is why when you look at YouTube videos, it's easy to understand, but actual hands-on, because they are already in an institute, they are already undergoing a training program. So at least in such training programs,
Scrubbing
towards
up
the
like a
end,
surgeon,
not just
maybe.
scrubbing up, but do they get to handle it on their own, independently?
So when they have a complication,
They are
depends on the
there.
confidence and the expertise of the fellow. Quite often they are able to do it to a certain level when somebody is there in the background. So on a case-to-case basis, not
Yeah,
as
I
a
know.
complication means I jump in. Who
Yes.
said I'm the best in handling complication? I may not do this, sir. The fellow may be better. So to the extent possible that they can handle, it is best that we observe them and chip in if you feel that your expertise is going to make a difference.
Thank you,
Dr. Saurabh, Dr. Radhika was stating that beyond fellowship, the alumni groups and all helps you to stay connected. But beyond fellowship, do you feel that everybody should go for a short observership course or instead of a further fellowship? And what could be the duration? Or should it be that there should be a time gap and they are into their practice and then they take off and go? Does it have any relevance at all?
Yeah, I think as I previously said, that as a norm, every year I visit at least one institute or a private practice 1 week in a year, so everyone can set their own time. So the idea is to cover the weaknesses that you find in your practice.
I will add one last point here,
Yeah.
expense of knowledge of time. But that said, I mean that is a very interesting and important point.
Yes.
But that said, I always emphasize to my fellow that you always perceive the grass beginner on the other side. You exhaust and you check whether you've exhausted whatever resources have been provided to you.
Yes.
These are on limited time. They're not going to come back to you again. You feel that this fellowship doesn't have this thing and that thing. But if it has 3 or 4 things that you've done under, please finish it up before you go outside. Look within yourself before you step.
Yes, very good.
Thank you so much.
Thank you so much, Dr. Radhika. You can see the passion, and I'm sure you must be a great teacher for your students. Yeah, very good points.
From you, it's like